video recorded presentations coming from India, from Dr. Vipul Gupta. He is a neuro interventionist from the Neuroscience Institute in India, and is going to present 2 successive lectures. The first one is strategies in the multimodality management of AVMs.
And I would have loved to be in Egypt. Because of some personal reasons I wasn't able to make it. And so I'm going to talk about strategies in multimodality management of AVMs. So AVMs, we know they're inborn errors of vascular morphogenesis with prevalence of 0.2 to 0.8%. Most deadly complication, of course, is intracranial hemorrhage, but seizures, headaches, focal deficits, or even tinnitus can be there in some patients. Now, most important when you're planning treatment is the risk of hemorrhage. Previous hemorrhage is definitely the biggest risk factor. If it has bled, 10 to 15% per year is the risk of bleeding, otherwise 2 to 4%. Some data says that periventricular or intraventricular location is also predisposition, deep location, arterial or intranidal aneurysms, deep venous drainage, single venous outlet or venous stenosis present in the main drainage, delay in the venous drainage, and perforator feeders. They're all been mentioned in literature as a risk factor. But there was a nice paper actually published in Neurology, and what this paper showed was that there are 3 major factors behind bleeding. Number 1 is deep brain location. Number 2, history of previous hemorrhage. And number 3, whether it's exclusive deep venous drainage. And once you calculate these 3, so the risk of hemorrhage can be 0.9% per year, vis-a-vis of deep-seated AVM, which has already bled, and isolated deep drainage, it goes to 34% as well. Now, what are the AVMs? AVM is a multimodality disease. Embolization, radiosurgery, surgery, or combined treatment between these things are always there. And we have to consider various factors when we decide strategy. Whether we want early occlusion, whether we want complete occlusion, what is invasive here or higher risk is there, permanence of occlusion, operator dependence is very important here, and availability of the proper expertise and is like in radiosurgery, the kind of system you are using can make a big difference. So if you compare, this was published in neurosurgery, these 3 in terms of being invasive, of course surgery is most invasive, radiosurgery is least invasive, embolization comes in between. Occlusion surgery is very good, radiosurgery is in between, and again embolization is in between. And same way we can compare all these 3 modalities have their pros and cons in terms of speed of efficacy, long-term reliability. Independence from size is the biggest advantage of embolization and is the biggest issue with radiosurgery. Independence from brain functionality is again an advantage of embolization, while independence from angioarchitecture is very convenient for radiosurgery, and independence from flow is also there. Of course, in radiosurgery, even when we don't have good access, they can do it. So a lot of pros and cons of 3 modalities. In our department, we always discuss with the radiosurgeons and the vascular surgeons before we take a final decision. So this is the algorithm which can be used. Number 1, you list patient-related factors like history, symptoms, family background. If you need multiple sessions of embolization, cost can be a significant issue. Analysis of AVM morphology then, like whether the location is there, whether good access is there, what's the size, what the vascular architecture, is it high flow, any aneurysms associated, then we decide. And the choice of treatment modality depending upon the patient needs, and then we see. It is useful to have considered these cases as well, like for surgery. There's a Spetzler-Martin scale for AVMs, which depends upon the size of the nidus, eloquence of the brain, and venous drainage, whether superficial or deep. And this various grading tells us that these are high risk or low risk for surgery. But of course, in non-eloquent areas, small AVM with superficial drainage is actually surgery is a pretty good choice in many of these patients. So we always calculate risk of the disease and the risk of the treatment depending on availability and expertise, and then we decide. To us, AVM is not a single disease. There are various AVMs are like different pathophysiology involved there. Then we do probability calculation that what is the best route for this patient. You have to remove your bias and ego there and take a calculated risk. Invasive, yes, somebody may think surgery is invasive, but at times in challenging AVMs, embolization, though outside may be invasive, but maybe a more invasive in terms of chance of complications. So again, we have to take a very considerate decision. This is a tricky disease to treat. So when we plan treatment, we are very clear. What's the purpose? Is it curative? We are doing embolization. Is it a partially targeted embolization? Some small pseudoaneurysm we are treating. Partially palliative. We are not looking for a cure. We just treat part of the AVM, let it be. Is it preoperative? Or are we doing pre-radiosurgery embolization? And then we target area, degree of occlusion, risk analysis, and we consult. So we have to be very clear when we embolize why and what are we going to do. In terms of technique, we always do under general anesthesia. We use Onyx or Squid, usually with detachable microcatheter. But when there are fistulas, reflux is not possible, a partial targeted weak spot occlusion, then glue is also useful. Venous occlusion, we like to avoid till the end when we are sure we are going for a complete occlusion. Post-op angio-CT is very useful. If surgery is planned, we do in same anesthesia. That means we start early in morning. We finish our procedure in 1 to 2 hours, and by the time the OT is ready for immediately in the same anesthesia patient, we found this same session embolization surgery to be a very good technique. Post-op BP monitoring, which whatever you do is very critical. And if there's a almost complete occlusion, or there are large fistula where you cause a flow change, then we keep the patient intubated, they repeat CT, and then extubate them next day morning. Therefore, ICU care and a good surgery backup are essential. So in terms of multimodality, to us, there are like 4 different segments we can consider: small ruptured, small unruptured, large AVM, and diffuse AVM as to how we go about it. What about small ruptured? Now, in this case, we want a quick treatment, right? So if embolization, if we do early, if there's a weak spot, we target it early. If possible, we do surgery with pre-op embolization. We know we can get a cure in these patients, already they have bled. But if you do embolization and surgery is not possible, or patient doesn't want it, or they do surgery, there's a residual, then we think about radiosurgery, not as a primary treatment. But very few patients in which both embo and surgery are higher risk, and patients opt for something less invasive, then only we think about radiosurgery. So this is a typical case. That's how we like to treat large frontal hematoma with vast MAC, medium-sized AVM. We plan for embolization surgery in single session. It's a non-eloquent area. We embolize with single catheterization. You get 95% of the AVM. Small bits we don't care, because patient is going for immediately in 1 to 2 hours. The surgeon is going to take out the whole AVM, so we don't chase the small bits any longer, which cause the trouble actually. And then the surgeon operated with ease. Surgery is very safe in this patient because it's like a tumor surgery then. Another patient, she was a doctor with a large hematoma in left temporal lobe, a mass effect. This is the AVM. One may think about doing it direct surgery as well, but it was being done at midnight. Went there, we embolized the AVM, and then surgeon took it out. And it's a very clean surgery. And thankfully, amazingly, patient was quite neurologically intact very next morning. So when this ICH with AVM, then what we like to do, we do detection of the AVM, and then we do identification of the weak spot and AVM relationship with the hematoma before treatment, and then optimally directed treatment. So we use angio-CT in these patients very commonly, as I will show you. This patient with a deep nuclear bleed, the AVM shows multiple aneurysms. We don't know which one is blood on perforator arteries. And what we did was this angio-CT. So we analyzed that which aneurysm is in the wall of the hematoma, and the lower one at the arrow points looked like the one which had bled. We catheterized that, and then we treated by glue embolization. So we do very selected using angio-CT. We analyze which part of the AVM has bled, and we treat accordingly. Another patient, multiple areas of dilatation. Patient has had a bleeding. Again, angio-CT shows this aneurysm where the arrow is in the wall of the hematoma. As you can see, is upper third image, and we can localize it, and then we targeted that part of the AVM. We microcatheter in the lenticular striate with balloon assistance, and the glue embolization was done for complete occlusion. Direct surgery is also very good option, particularly when AVMs are small, like this patient, motor cortex bleed, very small feeders, compressed AVM. The angio-CT images shows a small aneurysm in the wall of the hematoma, and then the AVM nidus is posterolaterally, we can see in the second image, and the last image you can see stretch arteries. For surgeon, it becomes very useful. They can transfer this angio-CT or vaso-CT images to their image guidance, and then do a very precise surgery and coagulation. They know exactly where the AVM is. Another patient with occipital bleed, AVM, and you can see there's an aneurysm there. And again, the 3D and the angio-CT clearly shows the hematoma and how the aneurysm is projecting into the hematoma. This is the weak spot. That is what we are going to target. 3D is also useful to analyze how to catheterize these arteries. We reach internidal location. And this is the proper penetration. When you're going for curative embolization, this is very important that you do a very deep penetration. Whole nidus along with this adjacent network has to be penetrated, then only we know we have got a cure. And this is the follow-up of the same patient. It was a complete cure. Fistulas, of course, then we direct embolize, bleed. You can see a large aneurysm there, and fistula from posterior cerebral artery, and a selected glue injection is very useful in these patients. Sometimes we don't want to treat the AVM completely. This was clearly a diffuse AVM of basal ganglia, but patient had bled multiple times because you can see in the deep venous drainage there was a big aneurysm along with pseudoaneurysm. But in these cases, embolization in diffuse AVM like this can cause damage to the parenchyma. So you do selected embolization. This is the microcatheter injection. We again use angio-CT for selected embolization. Partial embolization was done. You can see some damage because of the partial embolization, but you spared the internal capsule. And this is you can see the follow-up. The AVM is there, but the aneurysm, the weak spot, because of the lower pressure is already healed, and we let it be there. You try to treat these too aggressively, we can cause serious deficits to the patient. But exceptionally, like in this patient with a deep bleed, basal ganglia AVM with no good access, maybe in the current era we can try transvenous, but patient wanted conservative treatment, we gave radiosurgery with pretty good outcome. What about small unruptured AVMs? Radiosurgery does remain a good option. It's very convenient. We have a cyber knife in our unit, and previously we used to use gamma knife, very convenient for the patient with pretty reasonable outcome in good hands. But if there's a fistula or a weak spot, then we like to do embolization. And if patient agrees, then still, again, surgery combined with embolization remains a good option. So again, small bleed, deep AVM, good for radiosurgery. There was no bleed, this was just the enhancing AVM, good for radiosurgery. Another AVM, unruptured, patients love this, radiosurgery done, and the follow-up, it's completely gone. But unruptured temporal AVM, multiple feeders from MC and PC, but you can see there's clearly an aneurysm there. Then we like to embolize, 2 microcatheters placed. Embolization shows the network and is completely gone. Then we like to do embolization in such cases. Another patient, frontal AVM with a large venous aneurysm. Again, you don't want to wait for radiosurgery to work. And then we hand with the microcatheter placement, Onyx injection, and you can see on follow-up the AVM is completely occluded. What about large AVMs? They are much more difficult to treat. Particularly in our like in third world countries, not so rich countries, it's very costly also to do a curative embolization in these patients. So we are very careful in considering regarding the treatment aim and plan, patient counseling. Sometimes we reduce the size of the embolization and then send for radiosurgery or surgery. Multi-stage radiosurgery is sometimes used. We don't have much experience, but can be used as well. Conservative follow-up has come in for large diffuse AVM. Maybe it's better to just let it be. Cerebellar AVM, large, so we embolized, but when we embolized, we don't do patchy salt and pepper embolization. We leave one sector, we define sector for the radiosurgeon. That is very important, rather than patchy AVM, and then they can't do good radiosurgery. Small bit of AVM left on the top, and we just send for radiosurgery. There is some data that SRS in pre-embolized AVM, because of the presence of the Onyx, difficult in marking and delineation of the AVM, multiple scattered sectors, and whether Onyx reduces radiation penetration, that the effect of radiosurgery is not so good, and direct radiosurgery is better. So we should not do embolization for the sake of embolization. It should have a specific purpose to do before radiosurgery. Another patient, large AVM, planned for embo and radiosurgery. So we reduce the size of the AVM. When one small part, well-defined part is left, we send it to radiosurgery in this particular patient. Another patient, large AVM in frontoparietal area, feeders from MC and PCA, we embolized, and when small part was left, it was sent for radiosurgery, and the follow-up shows complete occlusion. Another patient with large AVM, you embolize as much as you can and then send for radiosurgery. Are there some situations we don't treat the AVMs? I think a lot of large AVM nowadays, if there's no weak spot, not so symptomatic, maybe we can just wait and watch. That's better. Particularly, you have to be very careful about the diffuse proliferative angiopathy. You know, when we see this diffuse AVM nidus, you can see the flow voids are intermixed with the brain parenchyma. That tells us that the large AVM, but we don't see that many flow voids. Even angiographically, one can see they are not so high of flow. Veins are not that dilated. These are diffuse AVMs, and trying to treat them will only cause damage to the parenchyma, and we will wait and watch. But whatever you do, it's a team approach because backup is very important. Complication happens all the while with all of us. Like this blood AVM, huge fistula, we embolized, but some part of the glue went into the vein. And then in these cases, one has to be ready to pursue the AVM to try to close it as much as one can. But in spite of that, that patient did have a post-op bleeding. So the way to avoid this kind of post-op bleeding is to embolize almost whole of the AVM. If by any chance you have occluded the vein, you have to be very aggressive. Like this patient with blood AVM, we were embolizing, but you can see in the second row, the glue went into the vein. So there was no choice. We pursued all the residual feeders, got a complete occlusion, and then knocked the patient out in the deep anesthesia. We placed the EVD for pressure measurements and for any eventuality of bleeding and decompressing the pressure. Thankfully, the patient did very well. In terms of radiosurgery, I also like to point out, it's very important to get a very good nidus delineation, and planning is the key. And using good equipment, one can get good outcomes. You can see the nidus, the radiation has to match the nidus, not give it too much. So we use CyberKnife with this linear accelerator on a robotic C-arm, which really helps in good planning. And us neurointerventionists, we sit down with our radiosurgeon to plan. Like this brainstem AVM with previous bleed, you can't make out much on the MRI. How can they plan it out? So that is the vaso-CT axial thin section images. We mark them out the nidus in red, that this is exactly the area to give, and that really makes the procedure safer in such patients. So I want to conclude by saying that cerebral AVM embolization is analysis of each case followed by strategy. Multimodality management is the key, I think. Aim of the embolization should be very clear. Why are we doing it? How much we are going to do? Are we going to combine this? Because that changes strategy of embolization. Radiosurgery and open surgery are very viable options. Team discussion coordination is very important in these patients. Conservative treatment is an option in many of the AVMs. And it is the venous occlusion, not hyperperfusion, which cause massive bleed. So if anyway you're doing embolization, there's venous occlusion, you have to pursue that case for complete occlusion by intervention or by open surgery. And as I showed you, some of the cases how we manage these patients. Thank you.
Now we go for the next lecture for the same Dr.